Okay, we're doing wounds, and this is I think the largest number of papers in the book. So I'm going to move fairly quickly through this stuff. Jim Roberts did this, and if you think I don't like bad literature, wait till you meet Jim Roberts someday. He doesn't like anything, and he'll tell you that right to your face. In any event, we spend a fair amount of time treating wounds in the emergency department. A lot of you who are family practitioners probably do wounds in your office. Stick your hand up if you do wounds. Do you keep suture material and all that kind of stuff and do it? Okay. Let's just, and again, as I get older and older, I do less and less to more and more people. I want the simplest, least painful, most rapid answer that costs the least amount of money. That's it. Cheap is beautiful in my mind. Don't spend a nickel if you can spend a penny. So let's look about this. Question number one, and again, we're going to go through a series of questions. People always talk about these massive wounds and this, that, and other thing. That's not what I do in the emergency department. Do I occasionally have a big wound? Yes. Just like if you're a family practice, you have a big wound, what would you do with them? Send them to the emergency department. You're not going to do that. You can't take the time to tie up your office to do that kind of stuff. And more than that, you don't do it anymore. Send them to the ER. Well, the truth of the matter is, this is a study out of CHOP, Article 1. This looked at urban kids, 2,843. What did we actually do? Almost 60% were less than 1 inch. That's what came in. I mean, that's honestly what's there, 60% less than 1 inch. And 86% required no involvement of surgery. And this is a teaching institution where they can just pick up the phone and call the surgery resident to come down if they want to. 86% of the time they needed nobody. Mostly we don't have that. The truth of the matter is we don't have that many truly big, complex ones. So let's take care of what we've got. Second, outpatient wound preparation, scrubbing, soaking. They went through doctors to see what they were doing. What were doctors doing? Everything, and none of it made any sense. So they actually said, what do you really do? And then they said questions like, you got any proof? They all went, Where did the doctors pick it up? From house officer training, just like they did before. Monkey see, monkey do. Now, we assumed that the people who taught us, well, they must have known something. That's called eminence-based medicine, not evidence-based medicine. The surgeons are best at this. Some guy who's quite eminent says, well, this is what we do. After all, how many people here grew up in the era when a woman had a lump in her breast? We did a Halsted radical. Why? Because, well, boy, this is a young crowd. I mean, literally, I must have scrubbed in on 70 Halsted radicals. It was a very common procedure. The truth of the matter is, Halsted was so big and so powerful and so mean in his day, he convinced people that that was the operation of choice. It's not the operation of choice. Well, same way with all this junk. Very little of it's proven. Let's say this. There is a variety of techniques out there. How do you prepare wounds? What do you do about these things? 2 centimeter wounds or less can be handled in most cases well without sutures. They can be handled without sutures. Scrub them up, put on and then we're going to talk about the treatments of choice and what they actually cost. And I'll tell you right now, I'm still a Steri-Strip guy. Why? It's cheap, it's fast. There's very little time. You don't open an expensive suture set. Opening the suture set's expensive, isn't it? You ought to see what we charge for that damn thing. And that's just to kind of just put in a couple of stitches. That's a lot of money. That's a whole lot of money. By the way, can you wash the wounds with plain tap water, or do you need sterile saline? Let's stop the discussion. Sterile saline in no study was better than sticking your hand under the faucet. Do not open a bottle. By the way, if they charge 48 cents 1,000 gallons where you are for water, it's about something like that. Maybe it's 50 cents. For 1,000 gallons. By the way, they can only have like 1 part per million, whatever it is, bacteria in that. Now you take the saline bottle, you unscrew that thing, and there's $4 tied up in that 1 bottle. You do the math on this. And there is no proof. Somebody said, well, the fact that it doesn't have saline in it means that you're going to lyse cells and change the healing. Crap. It didn't happen. Take them, stick them under the sink. And by the way, let me just tell you what I do. I'm a pain management guy. I don't think anybody ought to have pain for anything. I'm a pain-free doc. When they're at triage, just take, let's say they got a small cut on the back of their hand. Take a cotton ball, put Let solution or Let gel on it. Stick it in the wound. By the time I'm actually seeing them in 20 or 30 minutes, they're numb. I just take them, stick their hand under the faucet, wash it out with that, take a look. If there's no tension on the wound, steri strips. If it's a kid who I think will pick off the steri strips, sometimes then we use the expensive glue. But the expensive glue is cheaper than opening the suture set in our place. You know, if you actually look at what we charge for that kind of stuff, it's cheaper. By the way, this isn't even a close call, this stuff with the using the tap water. Every paper that's looked at this has supported this. 5, 6, 7, 8. We could have put 10, 12 more papers in this thing. Not one paper published to date in the English literature says the tap water isn't as good. Stick them in, take them to the sink, wash it out. Are sterile gloves needed? Absolutely not. Who pioneered this? The Germans. At the end of the Second World War, the German army was, after all, the last thing they were going to produce when you're losing, when you're running a retreat, is rubber gloves, right? Because they had to use their rubber for other things. And so what they did was they ran, as you would expect from the Germans, a beautiful set of studies as to their wound complication rates with their surgeons wearing no gloves and wearing gloves. No difference. Not one bit of difference. Understand this, when you're dealing with an open wound, is it sterile to begin with? No, by the way, how about a wound on the inside of the mouth? What about something in the vagina? How about something in the rectum? We don't deal with sterile problems. And article number 9, this is a Canadian study. Again, Canadians will be happy to save you some money. They basically said, use whatever glove you want. Because if you take the regular cheap gloves, the latex gloves out of the box and use those, same infection rates on wounds. Now, the reason you wear gloves is not to protect the patient, it's to protect who? You. Okay, it's not about the patient, it's about you. That's why we wear gloves. Now, the reason I will occasionally want sterile gloves is only because they fit better. If I'm doing an intricate sort of closure, and I'm using my loops and all that kind of stuff, I want something that fits very tightly to the hands, and the cheap ones don't. But a lot of the stuff I'm doing, cheap gloves. And of course, how many people here have ever broken scrub and not told anybody? Yeah, the difference is now, I just tell you. Yep, I dropped that on the floor. It's all right. Feel comfortable with that. You haven't done anybody any harm. Gloves are for protection of the patient, or you, not the patient. Question number 5. Can some wounds be cleaned, closed without irrigation? The answer, yes. Simple washing and not full irrigating had no difference on scalp and face wounds. Why? Because they're so vascular, they take care of anything anyway. I honestly believe you could defecate in the wound and it wouldn't become infected. Faces and scalps have blood supply which is unbelievable. I mean, isn't that true of your career? How many times have you ever seen the face pus out? You just don't do it unless you've got a pocket coming from the inside. It's just a rare event. Don't worry about it. Question 6. Are wound antiseptics and soaking wounds prior to repair helpful? Stop. This is clear. If you are putting people in 10% betadine, you are killing cells. It is useless. It's a waste of time. You dilute it down to 1%. What about that? Still too much. 1/10 of 1%, 1/100th of what comes in the bottle has the same killing power, and it has less damage to the tissue. Do not be sticking straight betadine out of the bottle into the wound. It is not useful. And I remember one time at the University of Michigan when I was a medical student, very famous old neurosurgeon, I mean old neurosurgeon. He still wanted colloidal gold curves on, patients. Somebody, one of the medical students was standing behind us, and he said, feel that tumor. Well, it just so happens that he was speaking to me at the table. There was a hand appear that wasn't gloved. And they put their hand in the tumor. Well, of course, it drove him crazy. And so he immediately says betadine, and he starts douching the brain with betadine. Well, shit, there goes high school. Hello? What happened to high school? What we know now is betadine is not good to the tissue. It's great to clean the skin off. If you're going to do a spinal tap or something like that, then wash it off with alcohol, but don't be sticking it against the open wound at 10% or at 1%. Here's what I actually do. I have them put 3 or 4 drops in the plastic cup and then fill it up with saline. Then I've got a little water with a little color in it. Patients like that. Okay, they really like that. And so I clean the skin edges and stuff like that, but soaking does no good. What about degreasers? Degreasers are okay on the skin, if you're doing the hands, but in the wound itself, they are no good. They are toxic to the tissue. That includes borax and gojo, that sort of thing. The annals of plastic surgery, and now the position of the plastic surgeons is inside a wound with grease, soap and water. Copious soap and water. Just don't do it. Question 7, tissue glue, yes or no? The answer is tissue glue costs money, and so if a Steri-Strip will do it, that's just as cheap and is good. On the scalp, how many people here tie the hair? I tie the hair all the time. All I want to do is put point A next to point B, somewhere in proximity. It just has to be close, right? I've never seen a lawsuit yet saying, I've got this scar on my scalp and it ruined my modeling career. I've never seen it. Never heard of that discussion. So to me, if I can get away with that, I'll do it. But the cosmetics of glue versus stitches is in 15, 16, 17, 18, 19, 20, 21, 22. This has been studied till hell will not have it. The answer is the same in every one. In a non-pressure area. See, I would never put a glue over your knuckle when you're going to go like that. Why? Because you may open it up. But in some area that takes no pressure, the glue was just as good as the stitches. It makes the kids a lot happier. And by the way, I snocker kids. If I got a kid who I've got to do their face, I am the most aggressive guy in the world about knocking them out. Here, drink this. 0.7 milligrams of Versed per kilogram in a Tylenol syrup. Wait 25 minutes, and you know when they're ready, because they look like this. And at the same time, they're holding a LET solution against the wound. You don't hear any crying in my place anymore. I think the sign of a primitive emergency department is one that still owns a papoose board. You don't know what you're doing. You're not skilled. The parents love that stuff. I've had parents say to me, can I have a bottle of that to take home? No, this is dangerous. Don't try this at home. Yeah, but you know what? Is it a pain in the butt? Yes. By the way, that varies department to department. But yes, we have to do it. But the truth of the matter is, this is 2006. We can make this a pleasant experience for everybody. I don't like to hear kids screaming, and more than that, we always lie to ourselves and say the same thing. Well, they're kids, they won't remember. Yes, they do. They remember just fine. The only reason we do it to them and not to Dr. Mallon back there, hi, Dr. Mallon, is that kids are small enough that we can gang up on them and hold them down. We wouldn't do it to adults that way. Well, we do. Oh, I haven't done a spinal tap in 10 years without sedating them. I just ask people right to your face, do you want this to be a pleasant experience, yes or no? And all of a sudden, they're in dreamland. It's the way to go. I mean, why in the world would you ever be, particularly with a difficult spinal tap or something like that, where you've got to enter 2 or 3 times? You know, fat person, old, collapsed vertebrae. I ain't going to do that. That's not the way to go. All right. 8, foreign bodies. Wooden foreign bodies, how you detect them. By the way, lawsuits in emergency medicine with regard to wounds are based on 3 things. Foreign body, and foreign body. Again, I've done this since 1976. I've done legal cases. I have never seen one case against an emergency physician on cosmetics that did not have a foreign body associated with it. Not one. It's foreign body. So think about the foreign body issue. By the way, your eyes can fool you. If there's a smashed glass, take a picture. Glass at the 99.5% level shows up on x-ray. Things above 0.5, the plastic surgeons did all those chicken leg studies where they took different sizes of glass and smashed them and shoved them in chicken legs and then took the pictures to see what they look like in tissue. And yeah, you can pick them up. And anytime there's glass involved, I warn every patient, could there be a piece of glass left? Yes. Might it work its way to the surface? Yes, indeed. I see people still who don't wear seatbelts who come in with tattoos across their forehead with all those little tiny marks. And I tell them right there, I'm not going to dig through your face tonight for every one of those things. I'm not going to do it. Will some of them work their way to the surface? You see, what makes people mad is surprise. Surprise equals anger equals distrust equals lawsuit. Will they work their way to the surface, these little tiny slivers? Yes, they will. You could spend your night tearing their face up looking for those pieces and not get them all. Just be honest about it. That's sort of what we have to do. So your eyes can fool you, particularly things like those tattoo wounds. And whenever there's smashed glass, be liberal about it. Wooden foreign bodies, study of choice these days is ultrasound by an experienced examiner. Ultrasound is relatively quick. Now, if you don't have it available, you got to do what you got to do. But a plain x-ray is a waste of time. If you're looking for wooden or organic material, plain x-ray is a waste of time. What about gravel? Again, Carrie Chisholm's article is 24, which is a good one. 0.1 millimeters was found reliably on ultrasound. That's pretty good. That's pretty decent. What are the rules of ultrasound? It's good for plastic, wood, organic material. If there's a debate, if you're not sure, you can settle that debate with CT or MRI. But those aren't cheap, and they're not always available. If I called up X-ray at 2 o'clock in the morning and said, I want an MRI on this wound looking for a piece of gravel, they'd be looking for my job the next day. They don't want to do that. So kind of use what you've got available. CT and MRI aren't cheap. So, by the way, ultrasound, unless you're trained to look for foreign bodies, I know a lot of emergency docs now are all trained in the use of the ultrasound for certain things. But understand, ultrasound is a technique which is operator dependent. You've all seen some ultrasound people who are fantastic, right? You've seen others who couldn't find a submarine in the Detroit River. They couldn't. And so just remember, this is not an objective test. There's a huge subjective component to reading on an ultrasound. Know who you're doing. We've talked about the glass. Again, the fact that your eyes can fool you. What about plantar puncture wounds? Huge amount of controversy about this. And understand this. Routine x-ray of a plantar puncture wound is a waste of time. Don't even bother. What about coring the wound? Has anybody heard about coring? Yeah, you take the knife and you core around. Punch biopsy, never proven. No data to suggest, and it may actually increase the risk of infection. Why? Because you've made more wounds that they're going to be walking on. So don't core these things. It's not useful. By the way, we probably overstate. 34 talks about overstating the risk of infection. We probably do. Let me see here. And if you're going to treat, if you're concerned, let's say they were wearing a tennis shoe, which is, what grows in tennis shoes? Pseudomonas. And so if you're going to treat, prophylax against Pseudomonas. That's the organism, which is the worst one. And then here's the real rule that you ought to keep in mind. After 72 hours, if they present with an infection, plan on either doing a bone scan or a CT or something, because what are you looking at? Osteomyelitis. Now, 72 hours ago or so, they stepped on this thing. Now they got a red swollen foot. The diagnosis here is not cellulitis. It is, do they have osteomyelitis? Because the treatments are different. The timeline on the antibiotics is different. And if they have an area of swelling, if the periosteum is raised and there may be fluid in there, that may be an operative question. So those are the people on who you become aggressive. By the way, do prophylactic antibiotics help in most simple wounds? The answer is no. Just get to the bottom line, it's no. The best study here, probably 39, I'd circle it, I'd look at it. 37 is also not bad. This 37 is Cunningham's study, which is a meta-analysis, which is always a problem. But basically what it says is if you're immunologically competent, again, for the AIDS patient, all bets are off. You understand that. If you've got Swiss or Burton's agamma-globulinemia or something, okay, I'll buy that one. If you've got a diabetic foot or something like that, I'll buy that one. But if you're immunologically normal, there was no difference in any of these wounds in starting antibiotics. Not one bit. And you know, we'd all like to think that that can't be right, but it is right. So I would carry on the discussion about, see, it's always easy before to talk to the patient why we don't start antibiotics. If you don't carry on that discussion and they come back in with an infection, it's harder to carry on that discussion at that moment in time. That's a political point, but I would keep it in mind. What about animal bites? Dogs? Actually, your dog is your friend in a lot of ways. He is man's best friend, and he's least likely to infect you. Most simple dog bites that are non-pressure, that are non-ripping of tissue, probably don't need antibiotics. The dog is your best friend. What about cats? What do you think? No, cats suck. Cats carry a lot of Pasteurella on their teeth, and the infection rate in cats is higher than it is in dogs. More than that, it's a penetrating wound, not a ripping wound. They have fangs that come down and inject. And so they're actually a very difficult wound to deal with. Now, they tell me, my friends who are in the military, that the worst bite in the world is the Iraqi camel. He has things growing on his teeth which are unbelievable. And by the way, you know, all people from this hemisphere who go to the Middle East, what do they want to do? They want to have a camel ride. Okay, there's huge groups of these people. If you've ever been to the pyramids, there must be 40 guys dealing camel rides. Well, you know what, a camel is not a sweet creature. It's a piss ass. And you know, if it decides to move that head, it's got a mouth that opens this big. If it grabs the top of your head and squeezes it, it can crush your skull, and the bacteria it sticks in are unbelievable. So tip of the day is don't take any camel rides, particularly in Iraq, okay? Because it's a serious problem. In any event, mammalian bites, Article 40 here is the article by Turner. I would use that as sort of my guide as to what to do. Dave Talon has Article 41, again, cats and dog bites, gives out some pretty good advice. And 42 talks about the old wound presenting. What do we mean by the old wound? Well, that's tough to define. I always remember the time that one of the residents was berating this woman about not coming in fast enough because it had been 6 hours since her cut. And she looked at him and said, yeah, the last 4.5 of it has been in your waiting room. Anybody ever had a 4.5 hour wait? Stick your hand up. Yeah, of course. So just be real careful how you peddle that. Whenever you say, oh, well, if we'd gotten to it earlier, then the last thing you want is them saying, you should have then had me in here earlier. But in the older wounds, there is some suggestion, again, these are the 12 to 24-hour wounds that are getting worse, that antibiotics may be useful. Let's see, human bites, obviously bad. And the rule of thumb is this. Human bites can be prophylaxed with augmentin, probably. But if there is actually an infection set up in the hand, this is referral to hand surgery for decisions whether they're going to go to the operating room. If you have Eikenella in a joint, you may kiss that joint goodbye if you're not careful. Whenever they come in, and of course this is all the emergency docs know this, whenever they have wounds across their knuckles right here, is that from a fall? They always say, well, I fell. And I always say something like, listen, if an ape falls who walks on their knuckles, what do? Do you know? They put their hands out like this. Nobody falls like this. When did you ever see anybody go like this when they fell? It doesn't happen. So I usually say this. I don't know what happened, but if there's any possibility that that could have been from someone's tooth, your entire hand could blow up with infection and we'll be cutting it off just near the elbow. Why don't you rethink that and tell me again? Then I usually get the straight story. But that's the story I want. I want to know, do we have to go to the operating room, yes or no? And believe me, if I think they've penetrated the joint, that's a referral to hand surgery, and I'm not going to deal with that because I think they ought to be washed out in the operating room. And Eikenella is a bad actor, and that is the principal organism in human bites. Let's see if we've got anything else here that's important. Oh, epinephrine. Anybody ever seen an epinephrine wound from the pen, the injector pen? I had one of those where a woman was going through her kid's jacket, getting it ready for spring. She puts it in there, the injecto pen. He's got the tip off. It gets her right there and shoots her. And so I actually have done what is suggested in this article, and that is the phentolamine digital block worked just fine. She was fine. Article 15 talks about that, but I don't have enough experience personally. I've never seen a series on this. Again, these are isolated cases, but there's an awful lot of kids who carry the injector pen around. And if they get it in a digit, the damn digit did turn white, and that impressed me. Now, what do you do after the wound has been treated or sutured or whatever it is? Answer, nothing. Now, we'd like to think, oh, daily bacitracin is the way to go. That's what the plastic surgeons would tell you. What about aloe vera? Though that feels really good. Aloe vera ought to be nice. See, all of that ought to be good. There's just no proof. Same way with the occlusive dressings. All the studies, occlusive dressing versus nothing did just as well. All right, last point, and we're done, and that has to do with what about the new tetanus shots, the TDAP. The new tetanus shots contain, instead of giving DPT, we give TDAP, and that's the one with the acellular pertussis in it. Pertussis is back around. In fact, there is a Canadian study which said 1/5 of the, and that's study number 58, that 1/5 of the patients with these chronic long-term coughs that they couldn't figure out, 1/5 of them were positive for pertussis. There is a strange feeling abroad in the land, and I don't know why this is, but there's almost like it's a governmental conspiracy to give immunizations. I have people coming in all the time now. We're not going to immunize our child. Well, we depend on something called herd immunity to keep this stuff down. By the way, I could make the case that giving people immunizations has been the best public health measure in the United States in the last 100 years. In fact, we're 2 vaccinations away from wondering why we train pediatricians at all. You give enough vaccinations and you're okay. Why this culture is now developing of non-use of the immunizations, I'm not sure, but I'll tell you what, we saw a precipitous drop in Haemophilus disease. When the Haemophilus vaccine came out, when I was a kid in medicine, bacterial meningitis in children was not an uncommon disease. Today, it's rare. I haven't diagnosed a case in a kid now in a year and a half. I used to be making two diagnoses a month back in the 70s. And immunization works. It's gone a long way. And so now they are going to be suggesting that when we give people tetanus shots in the emergency department or in your office, you give the TDAP, the Tdap, as opposed to the old TD. And by the way, they did the study to say, does it cause more reactivity? Because that's a real question. What's the cost-benefit analysis of giving this thing? Zero difference in the amount of reactivity if you give the good one or if you give the bad one. So you know what? Give the good one.